Hello everyone, welcome to the Doc Tutorial Surgery Residency Program. I am Dr. Gopal, your General Surgery faculty. Today we are going to learn about the first chapter, that is metabolic response to the injury. On this chapter, there are multiple essay questions and short notes can be asked in different university examination as well as a national board theory examination. So these are the examples of the questions which can be asked in the different examinations, like essay questions on the stress metabolic response to the surgery and the mediators of the metabolic response to the injury, and the short notes can be asked on this topic on the SIRS and the ERAS. SIRS, that is systemic inflammatory response syndrome, and the ERAS, that is enhanced recovery after surgery. So let's start with the topic, and this is the example of the question which is asked recently in one of the university examination. So the question was, discuss the stress metabolic response to surgery and trauma in a surgical patient, and write a brief about the mediators of the metabolic response to the injury. So this was the example of the long answer or essay questions which can be asked in the university examination. So let's start with the topic. So metabolic response is a basically response by the body to the any tissue injury, whether it is a surgical or a non-surgical, which affect the function of the vital organs. So basically this is a surgical stress response which is can be brought by the several pathways involving the hormones, inflammation related cytokines, and the neural circuits. And this alteration in the body metabolism causes dysfunction of the wound healing or alteration in the immunity, and which also affect the some function of the specific organ, and these changes are collectively known as a metabolic response to the injury. So these changes are basically designed for the damage or limit the damage of the body during the trauma or during the injury, but not all the responses or the effect of the responses are beneficial by any means, because the prolonged action of these responses may cause a systemic inflammatory response syndrome or a multiple organ dysfunction syndrome. So this is introduction of the metabolic response to the injury or a surgery. So the basic concept of the body is that the concept of homeostasis, it defines that it maintaining the constant internal environment that allows cellular process to function the optimally. This is the basic concept of the homeostasis. Body tries to maintain this homeostasis during trauma as well as surgery or during the sepsis also. So body tries to respond to the surgery or a trauma basically in a two phases. One is a early phase of catabolic phase and the late phase of anabolic phase. The catabolic phase is specifically characterized by conservation of the energy and the conservation of the circulatory volume. The characteristic features of the catabolic phase are, it begins at the time of injury, and the clinical features of catabolic phases are presence of hypovolemia, decreased basal metabolic rate, decreased cardiac output, hypothermia, lactic acidosis, and this can be achieved by muscle breakdown, loss of weight, hyperglycemia, and the sepsis, or this can be the effect of the catabolic phase, that is hyperglycemia, sepsis, weight loss, and the muscle breakdown. So this is the catabolic phase which start early in a period of after the surgery or a injury. Later on, the catabolic phase is converted into anabolic phase, which is actually a rebuilding phase, and it lasts for weeks. During the anabolic phase, the repair of the serious injury happens. So basically, there was an old concept of ebb phase, flow phase. This was mentioned in 1930 by David Cuthbertson. It indicates or it states that ebb plays start within the hour after the injury. It is characterized by presence of shock, and the flow phase, which is characterized by the catabolic phase, which lasts for days, and the anabolic phase, which is recovery phase, which is last for week. This was the old concept which was now removed from the recent edition of the Bailey, but they have mentioned about the catabolic phase and the anabolic phase of the metabolic response. So let's start with the basic concept. So the is a homeostasis is a foundation of a normal physiology, and we have to provide a stress free perioperative care to preserve this homeostasis following the any elective surgery. So how we can provide a stress free perioperative care? By providing the adequate resuscitation, surgical intervention, and proper critical care. This can return the severely injured patient to a situation in which homeostasis become possible once again. So by the way of resuscitation, surgical intervention, and the proper critical care, we can maintain the homeostasis of the body in a surgically critical patient. So the metabolic responses to the surgery that also influences the effect on the catabolism, effect on the functioning of the different organs, and it may cause adverse effect like a surgical inflammatory response syndrome and the MODS. So prolonged effect of this response may cause a SIRS as well as MODS. So, and the characteristic feature of the response given by the body is depend upon the nature of the injury. So it is a type of a graded response given by the body. So the response is directly proportional to the severity of the injury. So more the severe the injury, greater the response given by the body. So this graph predicts the response given by the body with respect to major trauma and the minor trauma. If there is a major trauma, higher the response, and if there is a minor trauma, the response is lower as compared to the minor trauma. And this is the decrease in the resting metabolic rate during the phase of starvation. This graph depicts the starvation. So the response by the body to the injury is graded, that is, higher the amount of injury, greater is the amount of response. So this concept applies to the physiological changes or metabolic changes as well as immunological changes which happens during the metabolic response to the injury. So the effect of metabolic response can causes rise in the temperature, increase heart rate or respiratory rate, or increase in the energy expenditure. So and there is an increased amount of the WBC count. So the nature of the injury is directly proportional to the response, or the response is directly depending upon the nature of the injury. Higher the injury, higher will be the metabolic response. So let's see the what is the systemic inflammatory response syndrome. There can be a short note on the systemic inflammatory response syndrome. So basically it consists of four components. It is defined as a presence of a fever more than 38 degrees Celsius or a hypothermia with less than 36 degree Celsius. Increase in the heart rate, that is tachycardia more than 90 beats per minute. Increase in the respiratory rate more than 20 breaths per minute, or arterial CO2 or PaCO2 less than 32 mm of Hg, and raise WBC count more than 12,000 per microliter, or WBC count less than 4,000 per microliter can be considered as a component of a systemic inflammatory response syndrome. or the presence of more than 10% of the immature or a banned form of the cell. So out of this, presence of two or more than two component defines as a systemic inflammatory response syndrome. And the main important primary cytokines responsible for the SIRS are the interleukin 1, interleukin 6 and the TNF alpha. So remember the cytokines responsible for the systemic inflammatory response syndrome, and it is basically mediated by the presence of a cytokine storm which is released into the systemic circulation, which causes a flare up of the systemic inflammatory response. And with the continuation of the systemic inflammatory response, if we have not done the proper resuscitation, critical care, the patient may go land up into the multiple organ dysfunction syndrome, which is defined as a presence of a two or more organ dysfunction, which is induced by the variety of acute insult including the sepsis. And the mortality during the multiple organ dysfunction syndrome is up to 40 to 80%. So the multiple organ syndrome characterized by the development of progressive and potentially reversible physiological dysfunction in two or more agent, that is induced by variety of acute insult including the sepsis, or it may land up into the septic shock. So let's start with the main discussion of the topic, that is mediators of the metabolic response. If you have a limited time period to read this entire chapter and you have to read only one side, so this is the slide which you can read before going to any theory exam, so that you can write essay question or a short answer question on answer on this question thoroughly, but just by remembering only this slide. So the mediators of the metabolic response are categorized into the two categories, like inflammatory mediators and the neuroendocrine mediators. So basically the inflammatory mediators are divided into two depending upon their appearance after the injury or a trauma or a surgery. The inflammatory mediators which appears within the 24 hour of the injury or a surgery, these are known as a pro-inflammatory mediators, and this includes cytokines, nitric oxides, endothelin 1 and the prosteroids. The important cytokines which are pro-inflammatory cytokines are interleukin 1, interleukin 6, interleukin 8 and TNF alpha and interferon gamma. Out of these, the interferon alpha and interleukin 1, these are the hyperacute inflammatory cytokines, and the interleukin 6 and interleukin 8 are subacute cytokines. So just remember the cytokines hyperacute are interleukin 1 and the TNF alpha, and subacute are the interleukin 6 and the interleukin 8. So these are the pro-inflammatory mediators. After the 24 hour of the injury or a trauma, body tries to balance these response by induction of the or a appearance of the endogenous cytokines antagonist, like interleukin 1 receptor antagonist and TNF soluble receptor 55 and 75 receptor antagonist. And there is a antagonistic effect by the pro-resolving mediators like lipoxins, resolvins, protectins and the resolvins. So these are the pro-resolving mediators which act against the cytokines mediator or a pro-inflammatory mediators. And there are adaptive changes happening during the after the 24 hour of the injury, which are known as CARS, that is compensatory anti-inflammatory syndrome. This is the body's try to reverse the effect by the pro-inflammatory cytokines. So it is mediated, the CARS is mediated by interleukin 4, interleukin 5, 9, interleukin 10 and interleukin 13, as well as TGF beta. The TGF beta is the most potent anti-inflammatory cytokine. So remember that the cytokines which appears within the 24-hour after the injury are a pro-inflammatory cytokines, and the cytokines which appear after the 24-hour of the injury or trauma, these are the anti-inflammatory cytokines. Out of this, TGF beta is the most potent anti-inflammatory cytokines. So this is all about the inflammatory response. Let's start with the neuroendocrine response by the body to the injury or a trauma. These response can be classified as an acute phase response and a chronic phase response. Acute phase response is a response which occur within hour of the trauma or surgery, and this is mediated by the increase in the concentration of the ACTH, cortisol, glucagon and the adrenaline, and these are the stress hormones which are responsible for the our body tries to increase this hormone for a short term survival. So these response is for short term survival, but because of the chronicity of this response, there is a occur hypothalamic suppression occur, which ultimately result in the decrease in the concentration of the serum concentration of the insulin, decrease in the insulin like growth factor 1, low levels of the T3 and the low level of the testosterone. So ultimately they result into the chronic muscle wasting, and this is the anabolic hormones. So there is a decrease in the anabolic hormones due to the chronic hypothalamic suppression. So this is all about the mediators of the metabolic response. You have to remember this slide as it is, so that you can write a essay question as well as a short note on this topic. So just now we have to see the effects of the inflammatory mediators. We have seen at what time which mediators are appears in the circulation, and now we have to see about the what are the changes that happens after the appearance of that mediators. So because of the injury on the body tries to increase the ACTH level or a growth hormone, which ultimately causes the adipocytes lipolysis, which increases the free fatty acid in the body, which ultimately utilized by hepatic gluconeogenesis to form a glucose as a source of energy after the trauma, injury or a starvation. So ACTH stimulated ACTH also stimulate the adrenal gland, and it will result in the increase in the serum concentration of adrenaline and cortisol, and there is a systemic stimulation of the pancreas which releases the glucagon. So adrenaline, cortisol, glucagon, growth hormone are the stress hormone which are increased after the injury or trauma, and they will causes increase in the hepatic gluconeogenesis, skeletal muscle protein degradation, hepatic acute phase protein synthesis like CRP, and the injury also stimulate the innate immune system. Innate immune system is also stimulated by the injury, and it will result in the appearance of the cytokines like interleukin 1, TNF alpha, interleukin 6, interleukin 8, and these responsible for the pyrexia, that is fever. So this is the response towards the injury by the body, and there is a decrease in the concentration of the insulin like growth factor 1, testosterone and T3, and ultimately there is a increase in the hypermetabolism, that is the metabolic rate of the body is increased, the basic energy expenditure of the body is also increased after the trauma, surgery or a sepsis. So these are the metabolic changes that happens after the injury or a trauma. So this is the beautiful chart given in the Sebastian which predicts or indicates all the changes that happens during the after the injury or a surgery. So the neuroendocrine response, as we have already seen, increase in the catecholamines, cortisol, glucagon, inflammatory response in the form of increased cytokines, arachidonic acid metabolite, acute phase proteins, and the increase in the oxidizing agent. And at the tissue level, there is a increase in the lactate, which causes the metabolic acidosis, will lead to stimulate the hepatic glycogenolysis, gluconeogenesis. Lipid complexes are utilized for the formation of the glucose by the hepatic gluconeogenesis, and there is an increase in the urea synthesis as well. So the prolonged effect of this catabolism or after the injury will lead to the muscle proteolysis, which provides the amino acid, which ultimately also utilized by the liver to form a glucose by the hepatic gluconeogenesis. And due to lipolysis, the fat cells are degraded into the increase in the fatty acid, which provides the glycerol, which ultimately converted into the free fatty acids and the ketones. And these ketones also can be utilized by the heart and the brain as a source of energy during the starvation. But the requirement of energy is high, very high during the after the trauma or surgery. So because of that, the metabolic response to the injury or a trauma, it includes the lowering of the ketogenic adaptation. So body cannot use the ketones as a source of energy in case of a trauma or a sepsis. Body relies on the source of energy by proteolysis and the lipolysis. So this is the flow chart which is given in the Sebastian, which depicts the response to the injuries. So let's revise the short and crisp the metabolic response to the surgery. So it is a rapid onset driven by the pro-inflammatory cytokines. Pro-inflammatory cytokines which appears within the 24 hour of the trauma or injury. These are the interleukin 1, interleukin 6 and TNF alpha. So the responses are graded, like more severe the injury, more severe will be the response. So the broadly related to the injury severity, most severe, that is the response is most severe in cases of the sepsis, burns and the major trauma. And there is a genetic predilection for the appearance of the this response. Like there are two persons in having the same amount of injury. The one person will may get a higher amount of response, but another person will may get a less amount of the response by the body. So it is depend upon the genetic makeup of the body. So it will lead to the catabolism, muscle breakdown and immunosuppression and the organ dysfunction or a failure. And these metabolic response is counter balanced by the antagonist response by the anti-inflammatory cytokines, but the balance may be imperfect. Sometimes the effect of pro-inflammatory cytokines will be more than the anti-inflammatory cytokines, or sometimes the anti-inflammatory cytokines response is more than the pro-inflammatory cytokines also. So it is prolonged by the response is prolonged by the sepsis, other secondary insults, and can be chronic. So if the response by the body may remain for a prolonged period, it may be chronic and it is associated with the late death from the injury or surgeries in the very developed health system. In a very developed health system, they try or there is a decrease in the mortality rate in the initial period of the trauma or injury by the adequate resuscitation, critical care. But this can be an unavoidable effect, which is metabolic response to the injury, which happens at the late stages, and this could be the possibly associated with the late death in an injury or surgical patient in a developed health system. So, what are the secondary triggers for the metabolic response to the injury? This includes the sepsis, hemorrhage, massive transfusion, acidosis, surgery, crush syndrome, and the ischemia perfusion injury. So, basically, these effect or these causes prolonged catabolic phase leading to the organ failure or immune dysfunction. So, these are the secondary triggers which prolongs the effect of the metabolic response. So, let's see the what are the metabolic changes that occurs at the body after the surgery or a trauma. So, basic concept is that after a trauma or a surgery or a acute hemorrhage or a shock, body tries to limit its resources and provide it to the vital organ like heart, brain, liver, kidney, and try to convert these sources from the muscle, adipose tissue, and skin and utilized to viability of the body. So, it is basically characterized by the four principles like there is a hypermetabolism, there is a hypermetabolism, there is a alteration in the skeletal muscle protein metabolism, altered hepatic protein metabolism, and the insulin resistance. So, basically body try to reprioritize the limited resources and which are utilized by the vital organ and which are obtained from the peripheral tissues and diverted to the viscera and the wound. So, the peripheral tissues like muscle, adipose tissue and skin, and the resources are utilized from these peripheral tissues and diverted to the vital structures or central tissues like liver, immune system, wound healing, or a heart and the brain. So, this is the changes, metabolic changes that occur after the injury or a trauma. So, let's see one by one why the hypermetabolism occur. So, the energy expenditure during the trauma or after injury increases up to 50% to 25% than the normal healthy resting values, and it is due to the increase in the metabolic rate, increase in the peripheral energy utilization, central thermodysregulation. This is due to the pro-inflammatory cascade like interleukin 1, interleukin 6, TNF alpha, which causes increase in the pyrexia. So, this can be also due to increased sympathetic activity like release of the adrenaline, noradrenaline into the systemic circulation. It is also due to abnormal wound circulation and increased protein turnover from the muscle into the vital organ. So, degradation of the muscle glycogen which ultimately produce the amino acids, and the amino acids are utilized by the hepatic gluconeogenesis for the production of the glucose as a source of energy. So, there is a increase in the metabolic response, that is hypermetabolism, and there is a energy expenditure is increased by 15 to 25%. And how can we decrease this hypermetabolism? By providing the adequate bed rest or external temperature regulation or by the proper ventilation. This is how we can minimize the hypermetabolism. Another response is alteration in the skeletal muscle metabolism. That is, so we have already seen that during the process of the catabolism, body tries to converts this energy from the peripheral tissue like muscles, skin towards the vitals organ like heart, brain, liver, and the kidney. So there is a degradation of the muscles happens, which causes increase in the protein turnover up to 1 to 2% per day. So there is a synthesis becomes equal to the breakdown. Generally, synthesis should be more than the breakdown, but during the catabolism, synthesis become equal to the breakdown. So the muscle growth, muscle growth is hampered during the catabolism, and the most commonly affected muscles by the catabolic phases are peripheral muscles, respiratory muscles, GIT. And just remember that the cardiac muscles are generally spared. So, what is the effect of the protein alteration or a catabolism, from the muscles? So, because of the respiratory muscle catabolism, there is a weakness in the respiratory muscle, which increases the respiratory infection. Respiratory infection is increased. So, because of the utilization of the proteins from the GI muscle or gut muscle, there is a weakening of the GI muscle, which causes the paralytic ileus. So, patient may remain in the ileus for a prolonged period. So, this the protein metabolism alteration or degradation is mediated by the mechanism, that is ATP dependent ubiquitin proteasome pathway. This mechanism is responsible for the catabolism of a protein or a muscle degradation. So, this is the second effect, that is alteration in the skeletal muscle protein metabolism. So, let us see the third effect, that is alteration in the hepatic protein metabolism. Just remember one thing, that is after the injury or a trauma or a sepsis, there is an increase in the transcapillary escape rate of proteins, that is specifically albumin. Increase in the trans escape capillary rate of albumin, so that the albumin which is present in the intravascular compartment goes into the tissue compartment, and during this phase there is a actually fall of a albumin level in the systemic circulation. So, during the acute phase of the wound or a trauma or surgery, there is a decrease in the albumin concentration, which is due to increase in the transcapillary escape rate and not due to the actual amount of fall in the albumin. So, albumin is diverted into the tissue compartment. So, albumin is considered as a negative acute phase protein. So, there is a decrease in the concentration of the albumin after a trauma or a injury. So, it is considered as a negative acute phase protein. So, let's see the what are the acute negative and positive acute phase proteins. So, remember that the acute phase proteins which increases after the trauma or surgery or injury or inflammation, these are the positive acute phase reactant, like C reactive proteins, serum amyloid, hepatoglobin, and ceruloplasmin. These are the positive acute phase reactant proteins. What are the negative phase acute phase reactant protein? Remember the name: albumin, transferrin, and the transthyretin, and the retinol binding proteins. So, there is an increase in the transcapillary escape rate of this protein, which causes increased accumulation of the protein from the intravascular compartment to the systemic or a tissue compartment. Because of this, they decreases in the systemic circulation and term as a negative acute phase reactant. So, this is the alteration in the hepatic protein metabolism. So, the acute phase proteins are also termed as a double edged sword, because it may also help in the recovery or repair during the surgery or trauma, but may also causes injury towards the body also. So, and just remember the negative reactant fall due to the increase in the transcapillary escape rate following the due to increased permeability of the vessel due to vasodilatation. So, these are the third effect, that is alteration in the hepatic metabolism. The last effect of the alteration is insulin resistant. Actually, during after the trauma or a injury, there is a post operative hyperglycemia develop. This is because of increase in the glucose production or because of the decreased glucose uptake in the peripheral tissue. and this happened due to because of the insulin resistance. And the causes for insulin resistance are due to presence of pro-inflammatory cytokines like interleukin 1, 6, TNF alpha, and the decrease responsiveness of insulin regulated glucose transporter protein. For example, the muscle, this is the muscle has a GLUT4 as a glucose transporter. So because of the decreased response by this GLUT4 towards the insulin, there is a decreased uptake of the glucose by the muscle cell, and it will result in the catabolism of the muscle, because the muscle is not utilizing the glucose because of the insulin resistance. So these are the metabolic changes towards the response to the injury or a trauma. So these responses are graphed as follows. During the major sepsis or a multi-organ failure, there is an initially increase in the weight. So just remember that there is an initially increase in the weight of the patient, and again the weight falls. So the initial increase in the weight is because of the expansion of the body fluid in the extracellular fluid space because of the overzealous resuscitation. Like we give a plenty of fluid to the patient in case of a sepsis, there is will be a slight increase in the weight gain, weight in initial period, and ultimately will fall, there is a fall in the weight. So in uncomplicated surgeries or in a starvation, there is a continuous fall of a weight. This is because of the catabolic effect of the body to the injury or a surgery. So just remember that during the major sepsis or multi-organ, initially there is a weight gain because of the overzealous fluid accumulation in the extracellular fluid space. So these are the effects, and for the appearance of this effect, there are multiple factors responsible which can be avoidable by proper resuscitation and critical care. What are the avoidable factors that compounds the response to the injury? The avoidable factors are continuous hemorrhage or a volume loss or a blood loss. This can be avoided by the proper surgical management or a packing or a ligation of the vessels. The other avoidable factors are hypothermia, tissue edema, tissue underperfusion due to prolonged shock, starvation, and the immobility. So these are the avoidable factors which, if avoided, can decrease the metabolic response to the injury. So this chart or this image depicts the effect of the metabolic response. Like there is a hypermetabolism, increase in the acute phase response, insulin resistance, and futile substrate cycling. That is, the amino acids are reutilized for a hepatic gluconeogenesis, and there is a muscle protein degradation which causes the cachexia. So these are the effect. If they are continued, will result in the catabolism, and it inhibit the anabolic process. So at this stage, if we intervene and do the proper resuscitation and the critical care of the patient, these effect can be reversed and body can go into the anabolic phase by proper providing rest, proper nutrition, proper adequate ventilation, oxygenation. So these are the avoidable factors. So let's see one by one why the volume loss is happen. It can be happen due to simple hemorrhage, which can be treated by the careful ligation of the vessel or a correction of the coagulopathy. The volume loss is also can be occur due to stimulation of the ADH hormone, which causes the fluid retention, and these also causes the sodium and water retention, and it promotes the peripheral and visceral edema. That is, these fluid are increased into the intracellular compartment, which causes the peripheral edema and the visceral edema, which is unhelpful for the body. So it will may causes the delayed gastric emptying, delayed intake of the food because of the peripheral and the visceral edema, and this may also conclude or causes prolonged hospital stay. So because this can be avoidable by just careful administration of the balanced crystalloid, this reduces the post-operative complications and it reduces the hospital stay. So this is why we should know the what are the avoidable factor and what measures we can take to avoid this the factor to decrease the metabolic response. Another factor, avoidable factor, is a hypothermia. This can be avoided during preoperative, intraoperative, or postoperative period by providing the proper garments like a upper body force air heating covers, which inhibits the hypothermia and reduces the complications related to the wound infection, cardiac complications, bleeding, and the transfusion requirement. Like that is, in a case of a major trauma, there is a deadly triad of the hypothermia, hypothermia, acidosis, and the coagulopathy. This triad is a major cause of death in case of a surgical patient with a hemorrhage or a acute blood loss. So these factor can be avoidable, and the correction of this factor can decreases the mortality and the morbidity in a surgical patient. So another avoidable factor is a tissue edema, as we have already seen. Because of the inflammatory response, there is an increase in the accumulation of the fluid in the intracellular compartment, which causes the tissue edema, which ultimately diminishes the alveolar diffusion of the oxygen, reduces the renal function, and this can be avoided by the adequate and proper resuscitation with the replenishment of the intravascular fluid, so that we can correct the extravascular fluid volume also. So another avoidable factors are the systemic inflammation and the tissue under perfusion, that is shock. Then this can be avoided by the proper infusion of the insulin infusion, which can maintain the normoglycemia and also inhibit the INOS, that is induced nitric oxide release, and administration of the protein C. So this can avoid the systemic inflammation. Why? Because induced nitric oxide, it causes the increase in the vascular permeability. Increased vascular permeability lead to the tissue edema. So this can be avoided by providing the proper insulin infusion to maintain the normoglycemia, and also it inhibit the excessive INOS, that is induced nitric oxide release, can be inhibited by the proper administration of the insulin. Another avoidable factor is a starvation. Generally body needs 100 gram of glucose per day to maintain a cerebral energy metabolism. So initial in first 24 hour, the initial period of the starvation, glycogens are mobilized from the liver and muscles, and ultimately the fat stores and the hepatic stores are utilized for the source of energy in the form of a gluconeogenesis. And this can be avoided by providing the proper nutrition at a particular time, like provision of 4% of dextrose, or avoid unnecessarily fasting. Early oral or enteral or parenteral nutrition can be provided so that it avoid the starvation and effect related to the starvation. So there is a term, that is a concept, that fasting before the surgery, but we can give a clear fluid 2 hours before the surgery. So just remember that 2 hours before the surgery we can give a clear fluid, आणि 6 hours before surgery we can give a food before the surgery. So by this way we can avoid the starvation. And the last avoidable factor, that is immobility, it should be avoided because the immobility may causes the DVT, like deep vein thrombosis, and it will may causes the pulmonary embolism. Another important factor regarding this is that the muscle, if this is the muscle has a GLUT4 receptor which are responsible for the intake of a glucose inside the muscle for the utilization as a source of energy, and these GLUT4 receptor are stimulated by adequate exercise and the mobilization. If the patient is immobile for a prolonged period, it will causes resistance of the insulin on this receptor, that is GLUT4 become inactivated, and the body muscle do not use glucose as a source of energy, and it will result in the catabolism of the protein that is muscle wasting. So immobility should be avoided by early immobilization after the surgery. So this is all about the metabolic response to the injury. We have seen about the mediators of the metabolic response. We have seen about the changes that happens after the metabolic response and alteration of the skeletal muscle protein metabolism, alteration in the hepatic protein metabolism, and the insulin resistant. And we have also seen the avoidable factor which can limits the metabolic response. And by the end of the topic, we have to see the one important concept, that is enhance recovery after surgery. There is a short note can be asked on this topic. Just remember that the enhanced recovery after a surgery, by this multimodality intervention, the output of the patient after the surgery is become improved because of the ERA's intervention, like in traditional care. So this curve is a of traditional care. The patients are admitted for a prolonged period in a surgical wards, and they may get a hospital acquired infection also, and there is a traditional care of keeping the patient for more than 5 to 7 days after the any surgery. So this was improved by the ERA's intervention, and we start doing discharging the patient as early as possible. We are going to increase the nutrition as early as possible. We are limiting the duration of the starvation of the patients. We are mobilizing the patient as early as possible after the surgery. So all these interventions are included in the ERA's intervention, that is enhanced recovery after the surgery. So the ERA's has improved the surgical outcome in a surgical patient. So this is the graph which shows ERAS has improved the surgical outcome. So the basic component or a basic concept in the ERAS is that try to do the surgery with the minimal access technology, like me laparoscopy, like a thoracoscopy, to avoid the major incisions which limits the function of the respiratory system, or it may causes the prolonged ileus. So these can be avoided by the using the minimal access technique. And the pain control is by blockage of the afferent painful stimulus is by analgesia, like epidural anesthesia. Epidural anesthesia can be used as a component of a enhanced recovery after a surgery. So there should be a minimal period of fasting, early mobilization to avoid the DVT and a pulmonary embolism related complication, and avoids the excess IV fluid administration. So because of the excessive fluid accumulation, it may causes the tissue edema or a prolonged paralytic ileus, and patient remain in the surgical ward for more than weeks because of the excessive fluid administration. So these can be the components of the enhanced recovery after surgery. So let's see the what are the components which can be done during the pre-operative setting or intraoperative setting or the post-operative setting to enhance the recovery of the patient. So the pre-operative components includes the proper pre-operative counseling of the patient, nutritional assessment, and the nasogastric tube. Nasogastric feeding is done in case of a significant stenosis of the esophagus, or a preoperatively general and incentive spirometry is started so that we can avoid the post-operative respiratory related complications. And we should avoid the smoking and alcohol intake 1 to 2 months before the surgery. And there is a concept of carbohydrate loading on the day of the surgery before the patient going for a surgery, like carbohydrate loading dose or a clear carbohydrate loading dose can be given up to 2 hours before the 2 hours before the surgery. So the no solid food given 6 hours before the surgery, and clear fluid can be given 2 hours before the surgery, and carbohydrate loading can be done at night before, from the night before the surgery up to the 2 hours before the surgery. And we should avoid, so in a previous days we should do the bowel preparation of any GIT related surgeries. So in ERA's protocol there is a no role of bowel preparation unless we have to use a colonic interposition for the placement, or colon used as a conduit in case of a gastric surgeries or a esophageal surgeries. So there is a no need of a bowel preparation unless indicated. So the intraoperative components of the ERAS protocol are provision of the prophylactic antibiotic, provision of the DVT prophylaxis. It can be in the form of mechanical or a pharmacological prophylaxis, judicious use of the intraoperative fluid so that increased amount of excess fluid will lead to the tissue edema and the paralytic ileus. So this can be avoided by the judicious use of the intraoperative fluid. We should avoid the hypothermia during the intraoperative period, and minimal invasive surgery should be done as if possible. And the pain control is by the epidural anesthesia. So these are the intraoperative component of the ERAS protocols. Post-operatively, we can do the enhanced recovery by adding nutrition, like on post-operative day 1 the carbohydrate drink can be started, and the patient should start the full soft diet at the end of the post-operative day 5. So in case of ERAS we should keep the patient NBM as minimum as possible. So the nasogastric tubes, like tubes, are removed on the post-operative day 1, and if these are not inserted if not necessary. Epidural anesthesia or patient control analgesia is used for a enhanced recovery, and early mobilization is achieved from the post-operative day 1 with the help of the physiotherapist so that we can avoid the DVT and the pulmonary complications. Urinary catheters are removed as early as possible, and if the monitoring of the urine output is necessary, then urine output can be monitored with the help of calculating the urine by another methods. And lastly, DVT prophylaxis can be given post operative also, like a pharmacological in the form of LMWH, and mechanical DVT prophylaxis instrument can be utilized. So this is all about the ERAS protocols. These are divided into pre-operative, intraoperative, and post-operative components. and by this ERAS method, we have increased the post-operative outcome of the patient. But the adverse effect of the ERAS is only that there are possible increase in the chances of the readmission because some patient we do a early discharge and they came with the some type of complications. Other than that, ERAS is a very good or a best protocol which is utilized during these days, so that we increase the outcome of the surgical patient. So this is all about this chapter, that is metabolic response to injury. We have seen about the metabolic mediators, SIRS, and the ERAS protocols. So thank you so much and all the best for the exam.